Good morning, ladies and gentlemen. Today's topic is very important as far as the dermatological practice in Pakistan and the neighboring countries is concerned. Because since last few years, cutaneous leishmaniasis has become the most common and most important chronic granulomatous skin infection, especially in army, where the soldiers are traveling to the endemic areas. This disease is of great significance. So in this lecture, I'm going to discuss not only about cutaneous leishmaniasis, but also about the mucocutaneous leishmaniasis and skin manifestations of visceral leishmaniasis. So let's proceed to the lecture. Introduction. Leishmaniasis is a protozoal disease, most commonly seen in tropical and subtropical regions, caused by an intracellular protozoan parasite of genus Leishmania that is transmitted by bite of a female phlebotomine sandfly. The clinical spectrum of leishmaniasis ranges from a self-resolving cutaneous ulcer to a mutilating mucocutaneous disease, and even to a lethal systemic illness. Cutaneous leishmaniasis is a variety of leishmaniasis in which skin is the primary site of infection. It has 5 different presentations that include cutaneous or localized, Leishmania recidivans, diffuse or disseminated, mucocutaneous, and post-Kala-Azar dermal leishmaniasis. Mucocutaneous leishmaniasis is seen primarily in Central and South America, and diffuse leishmaniasis is seen mainly in Africa, while the post-Kala-Azar dermal leishmaniasis is the skin involvement following visceral leishmaniasis and is seen both in Africa and in India, but it is an uncommon presentation. Species that cause visceral disease may also cause skin disease. Skin disease due to parasite of Leishmania brasiliensis complex may be complicated by the development of metastatic mucosal or mucocutaneous lesions, which are the destructive lesions of the mucosa. Commonly, the infection is zoonotic. One species of Leishmania may be associated with one or many natural vertebral hosts, which provides the reservoir of infection. So it is here important to describe what is a reservoir of infection. The infection reservoir in certain category of infections are those vertebral hosts which carry the disease but themselves are not suffering from the disease. And whenever reservoir hosts come in the life cycle of a parasite that is invading the humans, then such kind of infection is called as the zoonotic infection. Humans are commonly accidental hosts, although there are situations in which they may be the reservoir in an anthropogenic cycle. In such kind of cycle, which is an anthropogenic cycle, there is no reservoir, and the infection is directly affecting the humans, and the sandfly bites from the human source and carries the infection, and then when bite to another host will transfer the infection. And in such cases, the humans are the natural host, they are not reservoir, they are suffering from the disease as well as they are transmitting the disease. So such kind of cycle is called as the anthropogenic cycle. Certain diseases are characteristic and may commonly be associated with particular species of sandfly. The species are morphologically identical, the species of Leishmania, and, and are distinguished by isoenzyme pattern and DNA analysis. Monoclonal antibodies have also proved useful for the rapid identification of isolates, especially in the field. Incidence and prevalence. With the exception of Australia, the Pacific Islands, and Antarctica, the parasite have been identified throughout large portion of the world. It is estimated that 1.5 million new cases of cutaneous leishmaniasis occur annually, and more than 80% of the total cases affect individuals in developing countries like Brazil, Iran, Afghanistan, and Sudan. American leishmaniasis is an endemic and mainly rural disease of damp forest countries in South and Central America. The disease, leishmaniasis, is commonly imported into non-endemic countries by immigrants and returning travelers. Old world cutaneous leishmaniasis is mainly due to Leishmania major, Leishmania tropica, Leishmania ethiopica, and Leishmania donovani infantum. While American cutaneous leishmaniasis or mucocutaneous leishmaniasis is due to two species, Leishmania brasiliensis and Leishmania mexicana complex. The parasites have been redesignated by addition of a subgenus Viana, for example, Leishmania Viana brasiliensis, but in this lecture, the older and simpler terminologies are used. The optimum time for transmission is immediately after the rainy season, which is the breeding season as well. Additionally, Leishmania brasiliensis is becoming increasingly peri-urban, with number of opportunistic hosts, including dogs. Leishmania brasiliensis peruviana, in contrast, is a part of mountainous zoonosis and common among the peri-domestic dogs. In endemic areas where the transmission is stable, children are specially affected, and cumulative rate of infection is determined by the presence of scars and positive Leishmanian test that may approach 100% among the children of those areas. So these are the common areas where the cutaneous or mucocutaneous leishmaniasis is seen. You can see a major portion of Central and South America, mainly involving Brazil. Then in Africa, you can see the Northern Africa and part of the Central Africa, then whole of the Mediterranean region, north of Iran, and then Central Asian republics, Afghanistan, and northern part of Afghanistan, and some portion of Pakistan as well. So here you can see some portion of Punjab and Indian Punjab as well that is involved with cutaneous leishmaniasis. Epidemiology in Pakistan. In Pakistan, both zoonotic and anthroponotic cutaneous leishmaniasis is endemic in most part of the country that includes Balochistan, Sindh, Punjab, KPK, and Azad Jammu and Kashmir areas. Zoonotic cutaneous leishmaniasis is widespread over large areas of Balochistan, particularly in Sibbi, Lehri, Kolu, Dera Bukti, Dera Murad Jamali, Duki, Loralai, Khuzdar, and tribal areas, Khuzdar, and in addition now Gwadar. And in the tribal areas of KPK, which include Khurram Agency, Mahmud Agency, Bajor, Orakzai, North and South Waziristan agencies. So these are all the western part of the country that is in areas that are close to Iran and Afghanistan. Foci of anthroponotic cutaneous leishmaniasis is seen in interior Sindh, in southern Punjab, including Multan and Bahawalpur, and around the salt ranges, that is mainly the Chakwal district. The incidence is high among the children of indigenous population and non-immune immigrant adults and short-time settlers. Cutaneous leishmaniasis is a major health problem among the military troops stationed in various areas of Balochistan and KPK, as majority of them are from the non-endemic areas and they are the short-term settlers. Epidemic of cutaneous leishmaniasis occur whenever fresh troops move into the endemic areas. The endemic areas in Punjab, as we have already mentioned, it is worthwhile to mention few areas in Sindh, that is Jacobabad, Ladkana and Dadu, and few areas in Punjab, that is Chakwal, Khushab, Multan, Bahawalpur and Rahim Yar Khan. Pathophysiology. Most inoculations do not seem to result in clinical disease, as phagocytosis and complement-mediated killing of Leishmania parasites result in clearing of the infection. A minority of successful parasite inoculation result in localized or disseminated clinical cutaneous leishmaniasis. After a period of time, that is the incubation period, that depends upon the parasite species, size of inoculum, and host cellular immune response, a clinical lesion appear. This clinical lesion comprises of parasitized macrophages, lymphocytes, and plasma cells. As the activity continues for a few months and become chronic, more classical epithelioid cell granulomas are formed with giant cells. But there is little caseation necrosis. Once granuloma sets in, then the parasites are difficult to find within the macrophages. So these are the two ways the lesions of cutaneous leishmaniasis develop. That is the sandfly bite, resulting in injection of promastigodes through the epidermis into the dermis. These promastigodes within the dermis are converted into amastigodes and enter the macrophages. There is one type of cutaneous leishmaniasis in which the epidermis remain intact and the parasite continue to multiply within the macrophages, which is an non-ulcerative type of cutaneous leishmaniasis. While in ulcerative type of cutaneous leishmaniasis, due to intense inflammatory reaction and presence of large number of T cells and neutrophils, the superficial epidermis also get necrosed and ulceration forms. Rarely, when cell-mediated immunity failed to develop, as in diffuse cutaneous leishmaniasis, histology show masses of parasites, often parasitized, often vacuolated macrophages with little or no lymphocyte infiltrate, and normal or attenuated epidermis and no granuloma formation. So this is a typical histology of diffuse cutaneous leishmaniasis. Pathology of American cutaneous leishmaniasis and Mucocutaneous leishmaniasis. Pathology of skin lesions in this disease does not differ significantly from that of old world disease. The necrotic pattern with ulceration of overlying epidermis is more common than the non-ulcerated variety. Although recovery from infection confers lifelong immunity, but this immunity does not develop early enough or adequately to prevent the blood-borne metastatic spread of parasite of Leishmania brasiliensis complex, especially Leishmania brasiliensis itself, to mucosa of nose, mouth, palate, and larynx. This blood-borne metastasis is not seen with infections due to Leishmania major, Leishmania tropica, or even Leishmania mexicana. So this mucocutaneous variety of cutaneous leishmaniasis is seen only with infection of Leishmania brasiliensis complex, especially Leishmania brasiliensis. Here, they may later start to multiply, that is in the mucosa, and cause severe destructive lesions, which are known as spondia, which is a Portuguese name meaning a sponge. Histology of mucosal lesions show collection of lymphocytes and plasma cell around small arterioles in nasal or oral submucosa. Occasional leishmania are present in the vascular endothelial cells. Congestion and proliferation of vascular endothelium leads to desquamation and necrosis of overlying mucosa and underlying cartilage. And arthritis and thrombosis add to the tissue destruction. So this is a summary of all the Leishmania parasites. The old world Leishmania parasites, old world means the disease that is involving Africa, Mediterranean, Central Asia, and Southeast Asia. Leishmania, the species include those of visceral leishmaniasis that are Leishmania donovani, and among this list include Leishmania donovani, Leishmania donovani infantum, and Leishmania donovani shigasi. Then there are few species of pure cutaneous leishmaniasis, that is Leishmania major, Leishmania tropica, Leishmania ethiopica. In Pakistan and in Afghanistan, the main species are Leishmania major and tropica. Ethiopica is seen mainly in Africa. The Leishmania of the New World, that is in Central and South America, the species are mainly categorized in two categories, that is Leishmania mexicana and Leishmania brasiliensis. So Leishmania mexicana include Leishmania mexicana mexicana, Leishmania mexicana amazonensis, Leishmania mexicana venezuelensis. Then Leishmania brasiliensis include Leishmania brasiliensis brasiliensis, Leishmania brasiliensis guanensis, and Leishmania brasiliensis panamensis. The parasite. The protozoan Leishmania is an obligatory intracellular parasite which exists in two distinct forms. In the vertebral host, that is animal or man, the parasite occur as amastigote, which are round or oval in shape and 2 to 3 micrometer in diameter, and it is without the flagellum. In sandfly and in the artificial medium, they occur as elongated promastigotes, which are motile with anterior flagellum and 10 to 15 micrometer in size. That is almost 4 to 5 times size of a amastigote. So here these are the elongated flagellated promastigotes, and these are the round and oval amastigotes. If you see ultrastructurally, both the amastigote and promastigote carry a nucleus and a kinetoplast. Kinetoplast is the origin of flagellum. Even in amastigote, where there is no flagellum, kinetoplast is seen. The reservoir. Leishmania parasite may be associated with one or more natural vertebral host, which serve as a reservoir of infection, as I have told you before. The typical reservoirs include rodents, gerbils, dogs, cats, foxes, and jackals. All kinds of leishmaniasis in which the disease is transmitted from the reservoir is called a zoonotic cycle. So the sandfly bites the reservoir and injects the promastigotes into the reservoir. In the reservoir, the parasite multiply, and then sandfly take a meal from the reservoir, and in this way, the life cycle of the parasite continues. In such kind of cycle, man is the accidental host. When accidentally the sandfly bites a man, a human, and transmits the amastigote into the humans. There are situations in which humans become the reservoir and as well as the sufferers. And this occurs in an anthroponotic cycle, as I have already told you before. So sandfly, which is a vector, it belongs to a subfamily of phlebotomine, phlebotomini, and the genus is Phlebotomus in Old World and Lutzomia in New World. So the subfamily is phlebotomini, and the genus is Phlebotomus in Old World and Lutzomia in New World. The sandflies are 1.5 to 4 millimeter brownish insect or a fly having a long leg, narrow wing, and mouth that is adapted for blood sucking. A female sandfly lays 30 to 70 eggs in her lifetime. Sandfly found in Pakistan are Phlebotomus papatasi and Phlebotomus celiae for Leishmania major and Phlebotomus sargentii for Leishmania tropica. So in this diagram, you can see the egg as well as the larva form of the sandfly. Sandfly ecology and behavior. Sandfly live in dark, sheltered, humid, deserted places, in tree holes, in ground litter, foliage of the forest, rodent burrows, rock fissures, caves, cracks in the ground or in the wall of old buildings or kacha houses. Sandflies are the weak flyers. They make a hopping type of flight, and they do not disperse more than 10 to 20 meters away from their breeding place. Windy weather inhibit their flight activity and biting. So the sandfly usually don't come to you to bite, but humans go to the sandfly habitat to get bitten. Both sexes feed on plant sugar, but female in addition need blood for egg production and hence sucks blood. Bite is mostly at night, but may also bite man during day in dark rooms and thick forests. Most feed outdoors are exophagic, and few feed indoor, which are endophagic. They are unable to bite through clothes due to short mouth parts. The seasonal activity of biting range between April to November, which is the breeding season, with the highest incidence is from May to September. Life cycle. As the sandfly bites, 10 to 200 promastigotes enter the skin. They are taken up by macrophages, lose the flagella, and become amastigotes. So this is the diagram in which the sandfly bites a human, and from here, the promastigotes are phagocytosed by the macrophages, and promastigotes change to amastigote form and enter into the macrophages. And here in the macrophages, amastigotes multiply and in fact multiply, and the cells is ruptured, and then they infect other macrophages, and the process continues. So the amastigote multiply by binary fission within macrophages. Then sandfly feed on lesion of cutaneous leishmaniasis, and amastigotes are taken up by the fly. So this is a lesion of cutaneous leishmaniasis which was produced by the bite of this sandfly. Now another sandfly bite on the existing lesion of cutaneous leishmaniasis, and from there the fly picks up the amastigotes. These amastigotes are then transformed into promastigotes in the gut of the sandfly, and they divide in gut, and they migrate to proboscis of the sandfly, and from here the sandfly again bites another host, and the cycle repeats. So this is how the life cycle of cutaneous leishmaniasis runs. Immunological response. Clinical expression of the disease is mainly due to the immunological response of the host. The disease progression is associated with type 2 lymphocytes, which secrete interleukin 4, 5, and 10, while disease resolution is mediated by type 1 lymphocytes that produce interferon gamma and interleukin 2. Cell-mediated immunity is crucial for healing and lifelong immunity. Anti-Leishmania antibodies produced during infection do not correlate with resolution of the disease. Infection and recovery is followed by lifelong immunity to the same species of Leishmania, and in some cases, interspecies immunity have been reported. Clinical features, the old world Leishmania. Previously uninfected individuals are susceptible. Incubation period measures from months, but range from few days to over an year. One or more lesions occur on unclothed parts of the body, particularly on the acral skin that is easily bitten by a sandfly. Face, neck, arms are the commonest targets. Occasionally, lesions are seen on the feet and very rarely on abdomen and trunk, especially if the individuals are sleeping outdoors without wearing clothes. Lesions do not necessarily occur at exactly the same time, but in endemic areas, history strongly suggests that infected sandfly bites all the family members or all the members of a particular military unit at the same time. The natural history of lesions due to the four species tend to differ, but there is much overlap reflecting variety in the host response. The sequence of a nodule, crusting, ulceration, and healing with scar formation is common in all self-healing sores. The clinical features. Clinically, we broadly divide the features of cutaneous leishmaniasis as acute and chronic cutaneous leishmaniasis. So the acute cutaneous leishmaniasis include the rural or wet type, or urban or dry type, and cutaneous leishmaniasis due to Leishmania ethiopica, and cutaneous leishmaniasis due to Leishmania infantum. While the chronic cutaneous leishmaniasis include Leishmania recidivans, diffuse cutaneous leishmaniasis, and leishmanioma formation. Leishmania major, wet type, rural, or zoonotic cutaneous leishmaniasis. This has a short incubation period that is less than 2 months and starts as a red fruncle-like nodule at the site of inoculation. After 2 weeks, a central crust is formed. Crust may persist or fall away, revealing an underlying ulcer. The ulcer and raised red margin enlarge over 2 to 3 months, and the lesion reach a diameter of 3 to 6 centimeters. Multiple small secondary nodules sometimes occur around the lesion, which are called as the satellite lesions, or seen along the lymphatics, which are called as the sporotrichoid spread. Healing takes place in 2 to 6 months and leave a scar. This type of cutaneous leishmaniasis is acquired in rural areas where the infecting organisms are also rodent parasites and are poorly adapted to the humans. And this is an example of zoonotic cutaneous disease or zoonotic life cycle. So here is an example of an ulcerated cutaneous leishmaniasis. You can see the two ulcerated lesions on the neck and on the finger. Then volcano type ulcerated lesion is seen on the leg, and multiple ulcerated lesions in a sporotrichoid fashion is seen here. And you can see in this kind of these lesions, there are satellite small papules surrounding the central area. Here also. This is a large ulcerated lesion, and you can see the satellite papules as well here. Again, ulcerated type of acute cutaneous leishmaniasis. Then Leishmania tropica, dry, urban, or anthroponotic leishmaniasis. After an incubation period of more than 2 months, a small brownish nodule appears that becomes a slowly extending plaque of 1 to 2 centimeters in diameter in about 6 months. At this stage, shallow ulceration appear in the center, which develops a closely adherent crust. Multiple secondary nodules occur much less frequently than in the wet form, so the satellite lesions are less common in dry type as compared to the wet type, and after 8 to 12 months, lesions start to regress and ulcer heal, leaving a scar. The average time from the nodule to scar is about 1 year, and approximately twice as long as the wet form. Rare form of viscerotropic infection by Leishmania tropica is described. That is, Leishmania tropica rarely may go into the body system, causing visceral infection. And this kind of Leishmaniasis is anthropogenic type, in which the humans are the reservoirs as well as the hosts of the disease. So this is a dry type of cutaneous Leishmaniasis. You can see two other lesions of dry type. Again, 3 other lesions of dry type of cutaneous Leishmaniasis. Big lesions on the nose and surrounded by edema. This is a large nodular lesion of dry type of cutaneous Leishmaniasis. So differential diagnosis of cutaneous Leishmaniasis include other granulomatous infections like lupus vulgaris, deep fungal infections, tertiary syphilis, cutaneous sarcoidosis, while acute lesions resemble an ecthyma or fruncle or insect bite reaction. Cutaneous Leishmaniasis due to Leishmania aethiopica. This parasite is seen in African countries, and the lesion most commonly is seen on the central face and is usually single. Satellite papules accumulate into a large spreading nodule that may not crust or ulcerate. Lesions are seldom much inflamed and heal over 2 to 5 years. Then cutaneous Leishmaniasis on mucosal surfaces. The sandfly bite has been on mucosal border of nose, mouth. Primary mucocutaneous Leishmaniasis may develop, producing swelling of the lip and nose that persists for many years if ulcerated, although without gross destruction, as is seen in Latin America caused by Leishmania brasiliensis. So this kind of infection is not a blood-borne infection. It is just due to a normal bite of sandfly on a mucosal surface. So these lesions heal in a normal way, where that is the lesions which heal on the normal skin, but these are not destructive. They are not involving the blood vessels. They are not causing thrombosis and arthritis, etc. So these are the mucosal lesions. Here another mucosal lesion, which is destructive, but not that destructive as we see in mucocutaneous disease. Then cutaneous Leishmaniasis due to Leishmania donovani infantum. Whereas the infants infected with this parasite gets a visceral Leishmaniasis, adults are more likely to develop simple self-healing cutaneous disease without concurrent or subsequent visceral involvement. The appearance and evolution of lesion is typically slow and mild when compared with that of Leishmania major, with which it coexists in northern Africa. Then comes the chronic Leishmaniasis, and among the chronic Leishmaniasis, the disease becomes chronic if it does not heal spontaneously and not treated. It is seen in approximately 4% of Leishmania tropica infection in Iran and Afghanistan. One of the commonest type of chronic Leishmaniasis is Leishmania recidivans or leukophoid Leishmaniasis, that is characterized by brown-red or brown-yellow papules that develop close to scar of an old lesion or actually within the scar. The papules coalesce to form a plaque that closely resemble a lupus vulgaris, even to the formation of apple jelly nodules. The lesions worsen in summer and may ulcerate or form concentric rings. Rare keloidal, verrucous, and falciform types are seen. The recidivans lesion is a result of peculiar host reaction in which cellular immunity fails to sterilize the lesion despite the presence of exaggerated hypersensitivity. That although immunoglobulins are formed, but cell immunity is poor and treatment is not given adequately, that result in this kind of infection. The few parasites are left which result in recurrence of the infection. Although not as destructive as lupus vulgaris, the leukophoid Leishmaniasis may persist and spread slowly for many years. Investigations to demonstrate parasite or Leishmania DNA in affected skin is commonly negative. So here you can see multiple crusted papules developing around the scar area in this picture and on the scar here in this site. Again, you can see the scarring as well as papules, another case of Leishmania recidivans. Here again, you can see the papules and plaques coalescing into plaque and seen surrounding the scarred area of older lesion. Diffuse cutaneous leishmaniasis or disseminated cutaneous leishmaniasis. In the old world, this form of disease is due to Leishmania ethiopica and has certain characteristic features. There is an initial lesion which spread locally and from which the disease disseminate to other part of the skin, often involving large areas. The lesions are nodules that do not ulcerate. There is superabundance of parasites in the lesions. Histology is characteristic of macrophages full of proamastigotes. The internal organs are not invaded and there is no history of Kala-Azar. The Leishmanian test and other tests for specific cellular immunity are all negative. Disease progresses slowly and becomes chronic. Treatment produces only gradual improvement and relapse is the rule. Under the influence of treatment, histology changes towards tuberculoid in a portion of patients and they may recover completely. So this is a case of diffuse cutaneous leishmaniasis. This case remained under diagnosis for a long period of time with various different diagnoses like CTCL and erythema nodosum leprosum. But finally, it turned into diffuse cutaneous leishmaniasis, another case of diffuse cutaneous leishmaniasis. Then American cutaneous leishmaniasis and mucocutaneous leishmaniasis. So the cutaneous leishmaniasis may be due to Leishmania mexicana complex. Vector of Leishmania mexicana bites human reluctantly. So only those who spend long period of time in the forest, such as the chicle collectors, are at the risk. Lesions behave like those of Leishmania major or tropica. Most are on the side of the face or behind the ears. Lesion on the pinna and ear may invade cartilage and take many years to heal and destroy the pinna. Leishmania mexicana amazonensis is extremely common in forest rodents, but the vector is not anthrophilic, so human infections are rare. Large portion of them give rise to diffuse cutaneous leishmaniasis, which does not differ significantly from the counterpart in the old world due to Leishmania ethiopica. Then comes the new world cutaneous leishmaniasis or mucocutaneous leishmaniasis due to Leishmania brasiliensis complex. Sores are often large deep ulcers, usually with raised edges. Sores due to Leishmania brasiliensis guanensis is often fleshy and protuberant, usually on limb and multiple, and resemble that of yaws or pian boys. This parasite and Leishmania brasiliensis panamensis are especially associated with lesions along the draining lymphatics. The lymphatic lesions may remain discrete, small nodules, or may become inflamed and break through the skin, resembling the primary lesion. The deeper subcutaneous sores, also called as the volcano lesions, arise from the lymphatic spread of chronic sores in which scarring predominate and may present with difficulties in treatment. Lymphadenopathy is seldom marked. Cutaneous leishmaniasis due to Leishmania brasiliensis peruviana. UTA lesions are less severe than those of Leishmania brasiliensis. They heal spontaneously and not known to cause mucocutaneous disease. Immunity does not develop early enough or adequately to prevent the blood-borne metastatic spread of the parasite of Leishmania brasiliensis complex to mucosa of nose, mouth, palate, and the larynx. This I have mentioned before, and they multiply and are recognized immunologically and cause severe destructive lesions. So the initial lesion may be on an inferior turbinate or the septum and cause stuffiness and obstruction. The destructive pathology perforates the septum and over years may destroy nose, palate, and lips. So these are the severely destructive lesions involving the mucocutaneous areas. Here in this child, you can see the destructive lesion and loss of the nasal septum and also involving the upper lip. Severe destructive lesion, the whole of the nose and the central portion of the lip is destroyed. And this will come in the differential diagnosis of lethal midline granulomas. Criteria of diagnosis of cutaneous leishmaniasis. This is important because the cutaneous leishmaniasis is mainly a clinical disease, and many of the criteria here in the diagnosis are clinical. The first is the history of exposure to an endemic area in previous weeks or months. So this you must ask in the history. Then history of sandfly in the previous weeks or months. The patient might give a history of a sandfly bite. History of high-risk activities such as sleeping outdoor, jungle and desert trekking, and in soldiers, the military exercises. Non-healing chronic nodular violaceous ulcers that are formed 4 to 6 weeks or that are persistent for 4 to 6 weeks or longer. Then on investigation, demonstration of amastigotes in Giemsa stained smear from the infected skin by direct microscopy. Demonstration of intracellular amastigotes in dermis in H&E section. Presence of leishmanial granulomas in dermis in H&E sections. Growth of promastigotes in Nicoli, Novi, Macmillan, or triple and medium from the lesional specimens. And demonstration of leishmanial DNA by PCR. So it is not must that all the 9 criteria of diagnosis are fulfilled, but even a few of them are fulfilled, then the disease is labeled as cutaneous leishmaniasis. Investigations. There is a long list of immunological and non-immunological investigations which we perform. A few of them is done routinely and few of them are reserved for difficult cases. So the non-immunological methods of diagnosis are important, and these are the routinely performed, widely performed, and are very useful in diagnosis of this disease. First is the direct microscopic examination of the skin smear, then histopathological examination of the nodules, fine needle aspiration cytology, Leishmania culture in triple and medium, or animal inoculation. Animal inoculation is not a routine investigation. So type of smears which are performed in the diagnosis of cutaneous leishmaniasis. The first is the dab smear. The dab smear is made mainly by taking a skin biopsy and then dabbing or pressing the undersurface of the biopsy specimen on 2 or 3 glass slides. And because of the pressure, macrophages with amastigotes are attached in the smear, and then they are seen. Then slit skin smear. Then smear can be made by dental broche. Saline aspirate can be used to make a smear, or smear can be made by means of fine needle aspiration cytology. Once the smear is made on a glass slide, then right Giemsa Leishman stain is done and is viewed on the microscope, usually at 100 magnification. And in such magnification, you will then find the amastigotes within the macrophages. So these few pictures demonstrate how to make a slit skin smear. First of all, give an anesthesia, then hold the area by 2 fingers if possible, so that the field become relatively avascular. Then incision is made round about half a centimeter. Then by means of a 15 number blade, the lesion is scraped at perpendicular to the incision. And the material that is found, that is taken on the scalpel blade, is then smeared on a glass slide and fixed. This is how to perform a fine needle aspiration cytology as is done in other benign or malignant lesions. Saline aspirate. The way to perform a saline aspirate is to take an insulin syringe, fill it with half ml of normal saline. The normal saline is injected into the lesion, and without removing the syringe, the same as the fluid is aspirated into the syringe. And in this way, some amount of aspirate contains these amestigotes and is made seen on a smear. Here is how the LT bodies look like in a slit skin smear. These are the macrophage nuclei, and this is the cytoplasm containing many amestigotes. And here you can see these amestigotes, and 2 types of cells are seen. 2 types of nuclei are seen, the main nucleus and the kinetoplast here. This is a whole macrophage, and this is the nucleus. This one is a whole macrophage with cytoplasm. Histopathology of a lesion, of suspected lesion of cutaneous leishmaniasis is very important. In early stages, there will be a mixed inflammatory infiltrate, but later on, well-formed epithelioid cell granulomas are seen, surrounded by dense chronic inflammatory infiltrate comprising of lymphocytes, abundant plasma cells, and histocytes. Plasma cells are seen in all the infected granulomas. So the LT bodies are commonly seen. LT bodies are commonly seen in those lesions in which well-formed granulomas are not found, but this is not the rule. And these LT bodies are seen as small dots within the cytoplasm of the macrophages. So here you can see the multiple LT bodies within the macrophage. These dots are all LT bodies. All dots are LT bodies. The inoculation of the aspirate taken from the lesion into the triple N medium is not a routine investigation that is performed, but is done in special Leishmania laboratories. So once the Leishmania is grown in that medium, the smear is made and is seen on direct microscopy. And here you will see promestigotes rather than amestigotes, because the amestigotes convert into promestigote in culture and in the gut of a sandfly. Some immunological investigations that are done in cases of leishmaniasis include Leishmanian or Montenegro test and total lymphocyte proliferation assay. So Leishmanian test is a very useful test, also called as Montenegro test. It is a suspension of 5 × 10⁶ cultured promestigotes of Leishmania species. Leishmania major is commonly used for cutaneous diagnosis in old world leishmaniasis. Per ml of 0.5% of phenolic saline. 0.1 ml is injected into the volar aspect of forearm, and result is read at 48 to 72 hours. The antigen is normally standardized so that the induration of 5 mm or more measured by a ballpoint technique is considered positive. The intradermal test is not useful for diagnosis of current cutaneous leishmaniasis, as positive result may indicate previous sensitization. This is a positive Leishmanian test, and it is seen once the crusting stage has reached. The test is negative in diffuse energetic form of leishmaniasis. There are few tests that are based on humoral antibodies, immunity, or the serological test. These tests include the complement fixation test, indirect heme agglutination test, indirect fluorescent antibody test, ELISA, peroxidase and antiperoxidase tests. Antigen detection. This is done by DNA probe test or PCR. This PCR is more recently being done and has a diagnostic sensitivity that is significantly enhanced by using kinetoplast mini circle DNA. The sensitivity of test is reported to be 92 to 98% with 100% specificity. Variety of clinical specimens, including cotton swabs, smear, or paraffin-embedded skin section can be used as a DNA source for PCR diagnosis. There are few investigations that are reserved for species identification and not a routine investigation to be done. And for the species identification, excretion factor serotyping, isoenzyme analysis, monoclonal antibody, and molecular analysis of kinetoplast DNA is done. Management. In old world, most sores will heal spontaneously, but their duration cannot be predicted in an individual case. It is reasonable to try topical methods of treatment for simple sores and reserve the systemic use of pentavalent antimonials for the problematic sores. And these include sores with scarring, where scarring would be disabling or severely disfiguring, and sores that will not heal easily, for example, on the lower leg and over the joints, and sores involving the mucosa or cartilage, and sores that might be due to parasites of Leishmania brasiliensis complex. So I will end this lecture here, and I will record the second lecture after some time, so that you also get a break and I get a break too. So see you in the next lecture very soon. Thank you and goodbye till my second lecture.